In this video clip, we'll try to show how lung ultrasound can be a very useful tool to assess the presence of morphological changes indicating the involvement of lung interstitium in a patient symptomatic for respiratory distress with suspected COVID-19 infection. Basic lung ultrasound can be easily performed at bedside, even in the emergency setting. It is non-invasive, repeatable, and reproducible, and has a relatively short learning curve. Schematically, 6 different areas can be identified in each hemithorax, 2 on the anterior side, 2 on the lateral side, and 2 on the posterior side, by subdividing each side into 2 halves, upper and lower. All these 6 areas should be scanned if the patient is able to remain seated with the thorax in the upright position, whereas in those patients who can't stay up, the anterior and lateral side of the thorax, 4 areas overall, can be always assessed quite easily. One central point of examination per area is enough if the resulting image provides a satisfactory visualization of the related intercostal space. A convex probe like this one can be effectively used for lung EOS evaluation, as well as a linear high-frequency probe. Start using the probe perpendicular to the thoracic wall in a longitudinal scan with a marker oriented towards the head of the patient until an intercostal space is clearly identified on the monitor, which can be obtained by visualizing 2 adjacent ribs with their posterior acoustic shadows. Then, look for a transversal or oblique scan by turning the probe approximately 90 degrees counterclockwise and tilting the probe a little bit up and down until the ribs disappear and the pleural line is centered. This allows to enlarge the window of view and increase the length of the pleural line that can be examined on each area. The wider the view, the greater the chances of gathering the artifacts generated by the interaction between the EOS beam and the air and fluid content inside the lung. First, the pleural line must be clearly identified as a hyperechoic sliding line that moves back and forth during respiration. In a normal lung, the parenchyma beyond the pleura is not visible by EOS. Instead, a few hyperechoic horizontal lines at a regular distance one from the other and parallel to the pleural line can be seen below it. These are called A lines and testify that the corresponding area of the lung parenchyma is filled with air. A normal EOS pattern of the lung, also called A pattern, is defined by the presence of lung sliding and A lines. The second artifact that must be investigated is called B line. B lines are vertical, hyperechoic, laser beam-shaped lines that run from the pleural line down to the bottom of the screen. They move synchronous with pleural sliding and obliterate the A lines during their motion. B lines indicate that some fluid is present within the lung, which, in turn, has lost some of its aeration. The presence of less than 3 B lines in a single scan is considered a normal finding. Instead, a pathologic pattern called B pattern is defined when more than 3 B lines or coalescence of multiple B lines in a single scan are present, or if one or more focal thickenings of the pleural line called subpleural consolidations are visible. A score made of 4 progressive degrees of severity from 0 to 3, depicting the increasing loss of aeration of the corresponding area of lung that is being evaluated, can be given to each of the 6 areas. Here, 0 corresponds to the normal A-line pattern, including the presence of 1 or 2 B lines in a single scan, and refers to a normal level of aeration. Score 1 corresponds to a moderate loss of aeration, and it's defined as 3 or more well-spaced B lines, coalescence of multiple B lines, or subpleural consolidations, each of them involving less than 50% of the pleural surface. If the same parameters involve more than 50% of the pleural line, the resulting score is 2, which refers to a severe loss of lung aeration. Score 3 corresponds to the solid, tissue-like appearance of consolidated lung in which aeration is completely lost. Decreased lung aeration is not specific of pneumonia nor of the COVID-19 related pulmonary disease. Rather, it is only a sign of increased extravascular water density within the lung parenchyma, also known as interstitial syndrome. However, in the current setting of COVID-19 pandemic, we are experiencing a strong correlation between the above lung ultrasound patterns and the development of various degrees of interstitial pneumonia in the infected patients. Moreover, LungUS is allowing us to identify interstitial involvement at a much earlier stage than conventional chest X-ray, and therefore to promptly allocate patients to the appropriate level of care they require, regardless of the stage of the disease.